Hello. Welcome, 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 everyone, to the Doctor's Lounge presented by OBHealthy. You know, the Doctor's Lounge is a new name for us, and I'm so happy that we had come together and decided on this name because the whole thing about coming together as physicians, as Black physicians, we want to make it comfortable for you to come in and feel that you can type your medical question in and get an answer from a Black physician's perspective. And we're trying not to use the big words, try to put it in a way that you truly understand what the disease process or what's going on, such that you'll be better able to go to your physician and explain what's going on to. So that's where we're coming from. So the Doctor's Lounge is our new name, and I'm so happy that you're here, and so happy that we're moving forward, and so happy that we can bring this to you in a way that can educate the population of Black people out there. Well, we have two um things that are very important to us. Let me hold on for a minute. Let me click this off. The first one is that we're here to educate people of African descent from a medical perspective, number one. Number two, we're here to influence young Black males to go into medicine. At this particular point, it's coming to be a crisis. So we are adamant about any young Black male that's interested in science. We just would like for you to consider this profession because we need you badly. All righty. Understand that our webinar is every second Saturday of each month. It's at 1 o'clock, of course. And understand also that if you want to look at any of our past webinars, all you have to do is go to OB Healthy and hit that YouTube sign. And all of our past webinars are available. And understand also is that we want you to subscribe to our channel so we can continue to allow YouTube to bring this, to the audience that we serve. Okay. I'm just want to make sure I hit all the points here. So just want to tell you again, type in your medical questions because we're eager to answer them. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can best take care of you from a medical perspective. All righty. I'd like each and every one of the doctors to introduce themselves, and I will go in order that I see it on my screen. Dr. Ali, please introduce yourself.
Hi, good morning from the West Coast. My name is Mazhar Ali. I'm a gastroenterologist at Scripps Clinic in San Diego.
All right, excellent. And Dr. Court, please.
Dr. Court, a proud Howard University graduate, now practices in East Orange, New Jersey, internal medicine. Thank you.
Excellent. Dr. Kendall Sprott.
Yeah, I'm an undergraduate of Morehouse College and New Jersey Medical School. I'm a pediatrician.
Excellent, excellent. And Dr. Jordan Garrison.
Seeing we're all talking about undergraduate, I went to Lehigh University in Bethlehem, Pennsylvania. Okay, a lump of coal in a sea of snow. I am a board certified general and vascular surgeon, and I work in Hackensack, New Jersey.
All righty. Jordan, when you speak in the future, just come a little closer or bring your mic up just a teeny bit for me. That would be great. And we're so proud and I'm so happy that we have a guest physician with us today that, I've known and met many years ago. And he is, just someone after my heart because he's a pulmonologist, pulmonary critical care. I just love this. He's come here to bestow his knowledge. And I'm just so happy to have him. Dr. Leslie Kingslow. I'm just going to fess up. He sent me his bio, and I didn't get a chance to download it, but he's going to introduce himself and tell us exactly who he is, what he's doing, and brother, just lay it out for us.
Good morning to those on the West Coast. Good afternoon to all on the East Coast. My name is Leslie Kingslow. I am a board certified pulmonary specialist. I hail from Orange, New Jersey. My family Had a former physician, family member in Hackensack, of all places, was the first African-American physician at Hackensack Hospital. My father and my grandfather were both physicians, Meharry grads. I'm a Howard grad. I did my residency at the Medical College of Virginia in Richmond, Virginia. I did my fellowship in pulmonary and critical care at George Washington University Hospital. I'm an owner and partner of Pulmonary Critical Care Associates in Washington, D.C. I have medical staff privileges at MedStar Washington Hospital Center, Bridgepoint Hospital, both in Washington. I also hold privileges at Snyder Regional Medical Center in St. Thomas, Virgin Islands, and Mass General Brigham's at their affiliate at Martha's Vineyard Hospital. My expertise is in pulmonary medicine with a particular focus on pulmonary hypertension, COPD, and sarcoidosis.
Oh, excellent. Now that's a man after my own heart, sarcoid. We got to talk about sarcoid, brother.
Surely.
All righty. Excellent, excellent. I'm Dr. Omar Bey, and I'm a pulmonary critical care physician as well, with a subspecialty in nutrition. And I'm just so privileged to have these brothers with us, all this knowledge come together. What we're going to do is we're going to start off with a question because we have some questions coming through. And let's start off with this one. I have sickle cell disease and I get short of breath. My doctor tells me that it's my anemia. Can there be something else going on? Leslie, let's start off with you. This is a question that, and it's a very good question that's come through. Can you start off and just explain and or give us some idea, give this person some idea of what's going on?
Well, sickle cell disease is a well-known entity that afflicts African Americans, people of the African diaspora, in which because of a genetic malformation in their hemoglobin, their red blood cells sickle. They form this abnormal shape, and that sickling causes obstruction of blood flow into vessels throughout the body. Sickle cell and its manifestations in inducing shortness of breath are a number. Anemia obviously enters the consideration as a cause for shortness of breath. If you have a paucity of red cells, you have a paucity of those boxcars that carry the oxygen to the organs. And if those red cells are getting obstructed, there is an even further paucity of the ability of those red cells to get to the end organ and supply oxygen to those organs. But in addition to that, there's a scenario called sickle lung disease where because the sickle cells cause obstruction of the blood vessels that carry the blood into the lungs, the pulmonary artery, the bronchial artery, the lung tissue can become injured and infarcted, meaning that the tissue's not getting enough blood flow. And when it's not getting enough blood flow, the tissue can die. In addition to that, over time, the lung tissue can become scarred, and you can get interstitial lung disease related to sickle cell disease. And in addition to that, because of the recurrent crises of sickling cells in the pulmonary vascular bed, we have to recognize the pulmonary vascular bed is a very fragile bed. It doesn't like insult, it doesn't like trauma, it doesn't like inflammation, and it surely doesn't like obstruction. And when that happens over time, the vessel, a nice, normal, smooth lumened vessel, becomes irregular and thickened and hypertrophic. And the vessel actually narrows and becomes stiffer. And that can induce pulmonary hypertension in this population, which when we look at the literature, we find that is at the top of the list for causing morbidity and mortality as it relates to respiratory issues in the sickled patients. So those are the concerns for breathlessness in a patient who suffers from SS disease or even SC disease.
Mm-hmm. When you said a big word there, pulmonary hypertension, high blood pressure in the lung system. What is that? What it is? Tell me about that.
So the lay population and much of the medical community are well aware of high blood pressure, hypertension in our arteries that carry the blood out of our heart to the rest of the body. And that's, what we use these conventional antihypertensives to manage. But there's a disease that's a bit different from that called pulmonary hypertension. And there's two sets of that disease. There's pulmonary arterial hypertension, in which the native vessel arising from the pulmonary artery is damaged because of intrinsic disease of the vessel or a handful of underlying diseases that may induce it. And then there's secondary pulmonary hypertension, which arises from valvular disease or left heart failure, a variety of other diseases that are teased out and are a little different than conventional pulmonary arterial hypertension. And it requires a thinking cap to differentiate between the two, because the treatment of each varies.
Excellent, excellent. Dr. Sprout, you know, many years ago, you were my mentor in ICU and pediatric ICU when I did doing my fellowship. And I remember that we had patients. I can definitely remember we had patients that had sickle cell in the ICU. I mean, from a pediatric perspective in sickle cell, is there anything that you can give us some more clarity as far as from a peds perspective in sickle cell?
So I can, you know, sickle cell is, as was mentioned, it's a genetic disorder that basically causes the hemoglobin, which is a chemical structure within red blood cells that helps to carry oxygen. And over 95% of the oxygen that's in the blood is carried by hemoglobin. And when children are first born, their hemoglobin is uniquely different than the adult form of hemoglobin. And it's called fetal hemoglobin because it's the fetus that has this hemoglobin. And it's all fetal hemoglobin because when the baby is being carried by the mother in the womb, they're exposed to the mother's venous blood. And the ability of the oxygen to, I'll say, hang on to the hemoglobin is really related to how much oxygen is on that hemoglobin. This is a little complicated, but the more oxygen you have on the hemoglobin, then it's easier it is to release it. And so when you get red blood cells that go to the lung, it gets full of hemoglobin. The boxcars are full of hemoglobin. And then as it gets to the tissue, it starts to release it. And then the saturation, or the amount of oxygen on the hemoglobin, starts to fall. It never ever gets too low. But as the hemoglobin starts to get rid of oxygen, the remaining oxygen stays tighter. And so for the baby in the womb, because they're exposed to a lower amount of oxygen, they need to have a higher amount of hemoglobin. And so the amount of hemoglobin that a fetus has is somewhere maybe up to 20 grams %, whereas adults, you know, adult male might have a hemoglobin of 14 grams %. Now, if you start to look at what happens, because of once the baby is born, the baby is exposed to oxygen-rich air via the lungs. What happens is that hemoglobin gets fully saturated, and therefore the baby has an excess amount of hemoglobin, and the baby doesn't need to make new hemoglobin. And then as the baby starts to grow, the blood volume increases, and therefore the amount of hemoglobin that the baby has starts to become sufficient, and then it starts to drop. Somewhere around 3 to 4 months, it starts to hit a low, and at that point, the baby starts to make new hemoglobin, and that'll be the adult form of hemoglobin. Okay, and if the adult form of hemoglobin is sickle hemoglobin, then that baby will start to make red blood cells that have the sickle hemoglobin. Now, remember that when the baby starts to first make this new form of hemoglobin, the adult form, most of the hemoglobin is still fetal hemoglobin, which won't sickle. Those red cells won't sickle.
Right.
So sometimes around 5 months or so, the baby starts to have a sufficient amount of the adult hemoglobin, that'll sickle hemoglobin, that might cause them to start to have issues. And as was stated before, those cells might start to sickle. And by that, they become fragile. And when they pass through the spleen, which is where normal red cells are destroyed, they can get destroyed. And babies may start to have a problem with sequestration where a lot of their red cells get stuck in the spleen. The spleen starts to rapidly expand, and they have what we call a functional drop in the amount of blood that's circulating, and they can actually die. And so it becomes important, and one of the things that happens to every newborn in the United States is they do testing to make sure of certain genetic defects like sickle cell. And so if it's diagnosed that a child has an issue of either sickle trait or sickle cell, sickle trait is where you usually don't have the symptoms of full-blown sickle cell. They're told, because one of the things that happens to children is that the spleen, although it is a function of where you destroy red blood cells, they also are important in terms of trapping certain kinds of bacteria. And then you can make antibodies against them. So if you start to destroy the spleen because of sickling, then you become susceptible to certain types of bacterial infections that can kill you and overwhelm you right away. And so it becomes important for you to make the diagnosis and get vaccines against those types of bacteria that might cause you to die suddenly. And we saw, as you said, a number of children that had sickle disease and ended up having sepsis or blood, bacteria in the blood that caused them to get into trouble. And that can also be an issue related to, infection and damage to the lungs. Now, when you talk about hypertension, we talked about it briefly. Hypertension is an increase in blood pressure. And Dr. Atherley is here, and he can talk about the different, I'll say, pressure systems. But if you look at the heart has a right side and a left side. The right side, the upper chamber, receives blood from all over the body, and then it goes to the lower chamber and it pumps it to the lungs. And that right-sided heart is under a low pressure system, we'll call it. And the left side of the heart receives the blood that comes from the lung that's oxygenated, and that goes to all the organs in the body, and that's under a higher pressure system. But the reason that you have a pressure at all is really because of three things. One is how forceful the heart pumps. If the heart is weak and can't pump, then that might be a reason for low blood pressure. The second is the volume of blood in those blood vessels. And we can talk about certain kinds of congenital heart diseases where there's an increase in flow that goes to the lungs, and an increased volume in the blood vessels will lead to an increased pressure. And then the third is the vascular tone. Now the blood vessels, especially on the arterial side, have a muscular layer around them. And muscles respond to work. The more work they do, then the larger they get. And so if you have blood vessels that have a larger blood volume in going to the lungs, then that larger blood volume will lead to an increase in pressure. Right. And then that increased pressure over time, the muscles will start to get bigger, and that can cause an irreversible pulmonary hypertension. So certain kids that have increased blood flow to the lung because of holes in the heart or backflow can develop pulmonary hypertension that needs to be corrected. The defect needs to be corrected before they'll develop irreversible pulmonary hypertension, and then medication won't reverse it. So with sicklers, you need to understand that a number of things can cause the hemoglobin to sickle, one of which is acidosis, where if there's a problem with increasing acid in the blood, that can cause the cells to sickle. Another is a decreasing amount of oxygen that's available. That will also cause the red cells to sickle. So sicklers need to be very careful about having certain types of pulmonary disease that might compromise their oxygenation. If they have asthma or they have certain types of pneumonia and their oxygenation goes down, then that will cause the cells to sickle and cause a crisis where they can get very, very sick. And sometimes they can develop problems with the lung that require them to go on respirators. So it becomes important for the sicklers to understand what might cause them to sickle. And the other thing that might cause sickling that causes an increase in acid production is a decrease in the blood pressure. So if someone becomes shocked or becomes dehydrated, and one of the things that we always talk about with sicklers is to make sure that they aren't dehydrated. Because if you think about dehydration, all the cells with dehydration, certain types of dehydration, the cells will start to shrink. And if the red cells start to shrink, whatever hemoglobin is in them will increase in concentration, and that might cause them to sickle. So we always try and make sure, especially, during the summer months or when it gets hot or someone is exercising, that they keep hydrated, because that hydration will force water into the cells, keeps the cells to be slightly swollen, not a whole lot, but enough to maybe to keep them from sickling. So we like to advise the parents, and again, the parents will get referred to a pediatric hematologist, oncologist, where they can, number one, make sure that they get the vaccines that prevent them from getting sepsis or sick. And number two, to understand that they shouldn't have issues of dehydration, keep well hydrated. If they have issues related to the lung, asthma or pneumonia or anything that might cause them to decrease the oxygenation, all of those can cause a crisis to occur, which might cause them to have acute sickling, and especially damage certain other organs like the kidneys, where that also is a place where sickling tends to occur, even in individuals that might have trait. So it is important that they become aware. As a matter of fact, some of the treatments that have been used try to keep the sicklers to make that type of hemoglobin, fetal hemoglobin, that won't cause them to sickle. And there are medications that they can use to do that. There are things like bone marrow transplants that might be curative. But that's some of the issues that we faced in kids that had disease.
Excellent. Excellent. Dr. Atherley, you have your hand up, and believe me, Leslie, we didn't forget about you. We got a long show, so
I'm okay. I'm okay.
All right, Dr.
I'm
Atherley,
enjoying it.
First of all, I'm sorry I missed the introduction. My name is Trevor.
Please introduce yourself.
Okay. I'm an interventional cardiologist, primarily based out of Newark Beth Israel Medical Center in Newark. The reason I raised my hand was because Dr. Sprott more than adequately covered the role of the heart as a whole in pulmonary hypertension, but he did mention me by name, so I thought it'd be apt for me to just mention a little bit about the hypertension as such. And his description of the two hearts was excellent. We look at the heart always as cardiologists as the right side as separate and distinct from the left side. And the left side bears the brunt of pushing the blood throughout the body. The right side primarily pushes it to the lungs. But one can interplay with the other. In fact, it's often been thought that the most common cause of pulmonary hypertension, that's the right-sided, not pulmonary hypertension per se, but failure of the right heart, is failure of the left side of the heart, where the pressure is allowed to back up from a failing left side of the heart due to a distinctly different disease process from that is primarily affecting the right side. So we, looking at the left side more commonly as adult cardiologists, we are often to blame for the right side affected and causing pulmonary hypertension. But I will not go into details of the etiologies or the causes and the actual treatments, except to say that it is sometimes very important, not just for the cardiologist and the general physician, but for the surgeon to understand the cause of pulmonary hypertension when it occurs secondarily, and to understand whether or not there's a reversible aspect to it or if it's fixed. Because in some instances where we decide to do surgery primarily related to the left side of the heart disease, some of the valve diseases, etc., on the left side, and that, in fact, that pressure has so affected the right side as to be associated with irreversible pulmonary hypertension or high pressure on the right side, then it may put the patient at much higher risk for surgery, and the surgeon may in fact refuse to do surgery because of the consequences of trying to operate on a patient who has fixed pulmonary hypertension. Thank you.
Excellent. We have other questions here coming in, and there's one that says, I had COVID-19 over a year ago, and I remain short of breath. Is this what is referred to as long COVID? And I hear this all the time. Dr. Kingslow, can you tell us something about COVID period? And is there something, really, is there long COVID?
I think that it is an entity. What we're appreciating with a sizable percentage of patients who've suffered from COVID is that they have residual effects from that illness. As it pertains to lung disease, we find, in my practice, I'm finding a number of patients who are presenting with new onset asthma after having had COVID. I find patients who are presenting with new onset interstitial lung disease after having had COVID. I'm finding patients who are presenting with pulmonary fibrosis after having had COVID. So if a patient is noticing that there is a sustained degree of breathlessness, then it requires a workup. It should entail pulmonary function tests and a 6-minute walk test. I would also urge the patient to get an echocardiogram, with the understanding that we appreciate in this population evidence of cardiomyopathies that have arisen because of the insult from COVID, and consideration for a cardiac stress test to try to tease out what arena may be potentiating their breathlessness. But suffice it to say that long COVID appears real, and because this virus is endemic now, we're going to be seeing more cases of long-term insult from this virus.
Yeah, yeah. There were several things that you said that I'd like to see if we can explain to the public. Number one is in the workup that you were talking about, pulmonary function test. Excuse me. What is a pulmonary function test, and what does it show us? You know what I mean? How do you do it, and what does it show us?
So these are breathing maneuvers that are done by a technician who has expertise in coaching and directing a patient to breathe through testing. And they're breathing into an apparatus, a computer that measures lung airflow, lung volumes, the ability to move large segments of air within a fixed time frame relative to controls, as well as we're able to measure the ability of exchanging gases. We measured carbon monoxide, but it gives us an indirect measure of how oxygen and carbon dioxide is transversing across tissue planes within the lung. And from this, we can tease out the presence of certain types of diseases, whether there's airflow obstruction, i.e., the airways are collapsing on themselves because they've lost the elastic connective tissue in the airway. Or airways are restricted because the lungs are shrinking. They're shrinking because a big belly, or they're shrinking because there's scar tissue in the lungs, or they're shrinking because a segment of the lung was removed. And we can also measure that interface of gas exchange, which directs us toward whether it's an obstructive, restrictive, or a pulmonary vasculopathy, an issue with the blood vessels that carry the blood from the right side of the heart into the lungs. And that's what pulmonary function tests are. We also do 6-minute walk tests. And that's a very easy maneuver where we ask the patient to walk as fast as they can for 6 minutes without being coached. And we measure their distance, and we also measure their pulse rate as well as their oxygen level through a pulse oximeter, a device that measures the amount of oxygen connected to the red cells. And it gives us an indirect measurement of how much oxygen is in their bloodstream. And these maneuvers allow us to determine their relative fitness, how their pulse rate responds to exercise, how it responds once they stop exercising, and how far they can exercise within a fixed amount of time. And from that, we can extrapolate, how well they're doing relative to their respiratory illness, as well as whether issues with oxygenation are influencing that illness.
Right. I know the pulmonary function tests, and also, let me not move forward too quickly. The 6-minute walk test, I know a lot of times patients will come into the office talking about their short of breath. And this is one of the ways that we can determine whether they qualify for oxygen at home with COPD or whatever type of disease that they have at that particular point.
Exactly. I mean, CMS, the Centers for Medicare Services, sets guidelines for who can qualify for oxygen and who does not qualify for oxygen. And you have to have an oxygen level below a certain parameter, either at rest or with exercise, to qualify for oxygen. A lot of times patients will come in complaining of breathlessness and they're asking for oxygen, and it's really not an oxygen issue. And it's incumbent upon the provider, the internist, the pulmonologist, the cardiologist, to try to tease out what arena is inducing that breathlessness.
Right, right. True, true, man. That's excellent. Dr. Court, you got a question, please.
Yes, I do. For Dr. Kingslow, does vitamin D play any role in terms of the pathogenesis of the lung infection? And does it ever play a role in terms of long COVID if your vitamin D level is persistently low?
So there's a lot of literature discussion about the role of vitamin D as it pertains to lung disease. I have not run across any large studies that have been peer reviewed and double-blinded controlled studies that reflect any influence that vitamin D may play on lung health per se. We do recognize that vitamin D deficiency is important for bone health and a variety of other diseases, and it's incumbent upon us to monitor that and ensure that patients are adequately supplemented and have a normal vitamin D level. But with my experience, I haven't appreciated that vitamin D really makes a big difference. At the onset of COVID, there was a lot of interest in IV vitamin D and vitamin D supplementation as it pertained to this disease state. But again, I think that answer has been addressed, and there really hasn't been shown to be any substantial improvement with the disease state as it pertains to active COVID infections or long COVID in the setting of advancing vitamin D supplementation beyond what we already know with repleting vitamin D.
Excellent, excellent. Dr. Atherley, please.
Yes, I certainly concur with Dr. Kingslow, our speaker, about the existence of long COVID. I think it is a reality. I think there is some proof in several different arenas of its existence and its causation of diseases. A lot of patients whom I see who have had COVID do present to me with shortness of breath. And it's an onerous task for me sometimes to see if there's a real underlying heart or cardiac etiology or cause, as opposed to pulmonary, as opposed to other. So some of the tests that had been alluded to, which are done to look for function of the heart, may be usefully employed in this disease process as well as in other diseases. And one that was mentioned is an echocardiogram. Now, this is a very commonly used tool to assist us in looking more at the structure and some degree of function of the heart muscle. Essentially, the patient often lays on a table, laying on their back, supine position, and sometimes we change them from side to side to get better views of different angles of the heart. And a technician places a small machine over the chest with some lubrication and rubs it back and forth over the chest wall. This, in fact, sends signals into the heart, which are reflected back, and changes in acoustic density are recognized as lines and squiggles and coloration, etc. Blood flow can be shown as a color, depending upon the direction in which the blood is flowing, whether it's naturally flowing forward or whether it's leaking backwards. And these can all be used to define the structure of the heart muscle, the strength of the muscle, the size of the heart muscle, the function of the heart. And sometimes we use these to try to define whether, in fact, there's truly some disease that is actually affecting the heart, as opposed to something outside of the heart causing similar symptoms. Now, I do believe that the entity of long COVID does exist, and that we were able, in fact, with some even more sophisticated tests, to show the effect of the COVID virus on the heart. Very early in the disease phase, when the active disease was occurring in the 2020, 2021 era, for example, there were several studies which came out. One was among otherwise, what would one have considered otherwise quite hearty, healthy young males who contracted COVID. And even after recovering fully from COVID, some sophisticated disease testing did show disease involving the structure and the function of the heart muscle, what we called myocarditis or cardiomyopathy. Cardiomyopathy generally refers to a longer effect where the function of the heart is impaired significantly, and the myocarditis may be the actual inflammatory process, the inflammation which occurs early in the disease or may continue as a residual. So these tests did show that there was some activity going on in the heart muscle, which we related to and felt was caused by the virus actually involving the heart muscle directly. Of course, there are many ways in which the virus, the COVID virus, may affect it secondarily, but primarily affecting it. So one of the tests that is used nowadays is the MRI, magnetic resonance imaging, which gives a bit more sophisticated look at the structure of the heart muscle and can show if there's an acute or continuing process going on, or if we're seeing residual effects from an old process which did occur and damage the muscle. So yes, COVID myocarditis has been documented.
Mhm. I have a question. Give me a moment, Dr. Sprott, and you're next. Pulmonary embolus with long COVID. Have you found that patients who had COVID or has COVID have a tendency to develop pulmonary emboli? And maybe you could give us a little explanation of what a pulmonary embolus is and whether it's associated with COVID.
Sure. Well, we recognize that in COVID, it causes an array, a cascade of events that makes the blood hypercoagulable, thicker than normal, based on chemicals that are released induced by the illness. So this population is in and of itself predisposed to forming clot. On top of that, if you look at the conventional intensive care unit patient who is critically ill, regardless of the insulting nidus, these patients also have an increased propensity for forming clot. A pulmonary embolism is a clot that has arisen from a different location in the body, most likely the larger veins of the pelvis and legs, and that clot has become dislodged for one reason or another and traveled through the venous system into the right atrium, got pumped into the right ventricle, then pumped into the pulmonary artery, where as the artery tapers, the clot wedges itself into the artery. Mm-hmm. There's different sizes of clots. We can have a clot that is so large that it can occlude the entire trunk of the pulmonary artery. Imagining that arising, it would entail that there's no real blood flow exiting the right ventricle, hence no blood flow getting into the lungs, hence no blood flow getting into the left ventricle to be sent to the rest of the body. And in that scenario, the mortality rate is well over 50%. Mm-hmm. And then there's smaller clots that can form into smaller branches of the pulmonary vascular bed, inducing certain different levels of morbidity and also the potential risk for mortality. So to answer your question, we do see an increased propensity of patients with COVID suffering from acute pulmonary emboli. And the supposition is that early on in this disease state, when we were finding so many people deceased in their homes from this disease, given the acuity of their demise, the sensibility was that these patients were probably throwing emboli and inducing their mortality. Mm-hmm. In my patient population, I do have a reasonable cadre of patients who had pulmonary emboli during their acute illness and now suffer from the residual effects of that, whether that be residual pulmonary arterial hypertension because the vessel of the pulmonary artery had become so compromised and damaged and thickened that it didn't maintain its resilience, or that they have chronic clot, they have chronic thromboembolic disease. Are you able to hear me?
Yes.
Okay. They have chronic thromboembolic disease that that still requires our need to address that to try to reduce the morbidity and potential mortality that portends.
Excellent, excellent. Dr. Sprott, please.
Yeah, people should understand that with all viral infections, the virus can't reproduce on its own. It can only reproduce itself if it's within a cell. And different types of viruses like different types of cells. You know, the RSV, respiratory syncytial virus, the rhinovirus, and COVID. They like the respiratory cells, those cells that line the respiratory tree. And so they get into the cell, they reproduce, they kill the cell, they release itself, it then affects other cells, and so there's this cascade effect. And so when you think about the COVID testing, they're testing for pieces of that virus that have been in respiratory secretions. And they when you first are exposed to it, you might not be able to show that you have the virus because it's not yet gotten in and taken over some cells. And so a lot of people that got it didn't start to test positive until maybe 4 or 5 days after they were exposed to someone that had it. But people should remember that most of the individuals that first got exposed got a little bit sick, and then they got very, very sick. And those individuals that got very, very sick had what was called, like, I'll say a chemical storm that caused a great degree of inflammation, especially in the lungs. And when you get that kind of damaged inflammation in the lungs, it becomes difficult to keep the air spaces in the lung open, and it becomes difficult for you to exchange oxygen getting into the red blood cells, and also for CO2 to get out. And so a lot of the individuals that got very, very sick a week after they had gotten it, got admitted to ICU. Many of them stayed for days and days. And there's a difference between those individuals that continued to test positive for COVID. That meant that, with most viral infections that you get infected, it's around for maybe a week to 10 days, and then your body clears it. And once the body clears it, if you test for it, you won't be able to see it. But there are some people, a small group of individuals, that continue to test positive. That means that the virus was still growing in them. And we don't know, we still are trying to find out that the virus, we know likes the respiratory cells, but it can like other cells as well. And Dr. Athley talked about heart cells. Sometimes you can think it may be even in brain cells, and it can give you some kind of this fog or whatever. There's this fatigue that occurs. There's a lot about what goes on that we don't know. We certainly do know that one of the things that became very, very important is to try and prevent this inflammation that took place by taking anti-inflammatory drugs early on so that you didn't get the type of damage that occurred. But a lot of the people that got COVID never got admitted to the hospital. So they got sick. They weren't sick enough to get admitted. They stayed at home. And for many of them, we don't know the long-term effects or the damage that might occur to them. We know that they probably weren't damaged severe enough to get them admitted to the hospital in an ICU and on respirators, but the long-term damage to them that some may have, and sometimes it may be subclinical. And that becomes important if someone has shortness of breath, to see whether or not they may have some pulmonary lung disease, and that might be causing them to have these issues. The same issue related to, we talked about chronic respiratory disorders like asthma. And you can have something like asthma, may not be caused by what we typically talk about the triggers, but if you have a damaged lung, that damaged lung might be a lot more sensitive to allergens or to cold or to the normal triggers for asthma. And even though you didn't start out by having asthma, you might have asthma-like symptoms. So anybody that has shortness of breath, and again, a lot of folks that got COVID didn't even know they got COVID. If they're having respiratory symptoms, they might want to get these pulmonary function tests to see what might be done. Certainly, you can't go and now treat the COVID, but you need to be understand that the damage that occurred to the lung might be amenable to some types of treatments, and you might be aware that you might need to take something like a bronchodilator or a combination of a bronchodilator with a steroid that might help with some of the respiratory infections that they may get that might trigger asthma-like symptoms. So I think it is become important for individuals to talk to their doctors, their primary doctors, about maybe getting some pulmonary function tests if indeed they might have had some lung disease from COVID or some of these other viruses that might cause long-term damage.
Excellent.
Omar,
Yes,
can I piggyback on that?
Oh, yes.
So you prompted some interesting thoughts along this subject line. As I mentioned earlier, there is a cadre of patients who do present post-COVID with interstitial lung disease, and there is a body of literature that's looked directly at these patients and the role of protracted courses of systemic corticosteroids in the management of those interstitial changes, with data that's reflecting that a percentage of these patients do get better with a long course of systemic steroids. We're talking 3 to 6 months, accepting the untoward side effects of long-term steroids. Secondly, as many of us are well aware, there in the setting of chronic interstitial lung disease induced by idiopathic causes or connective tissue diseases or sarcoidosis, there are 2 medications that have been available to us for almost a decade now for the management of the fibrotic component of those diseases. And those medications are Esbriet and Ofev. And for a more elementary explanation as to what they do, they help to preclude the cross-linking of the scarring phenomena that arises in the lung and slows the progression of scar tissue in these populations. And these medications have been looked at in patients who have interstitial lung disease due to COVID, and it's been approved. They've been approved by the FDA for use in that arena as well.
Excellent, excellent. Dr. Court, you had your hand up, and was there a question you had?
Most of it was answered before, but I just was wondering if there are any pathognomonic features of, and especially in the lung, in patients who have long COVID.
I'm sorry, I missed the question.
Was there any features that shows up in the lungs in patients who have long COVID?
There's nothing about the changes that we might see in the lung as it pertains to long COVID that we can differentiate, that allows us to differentiate long COVID from any other disease that afflicts the lungs. So we can get bronchiectasis from long COVID. We can get scar tissue from long COVID. We can get pleural fibrosis from long COVID. But there's no biomarkers or any testing that tells us exclusively this is induced by long COVID. The only thing that we have at our disposal is the retrospectoscope. We can pull old films, review any films that we may have had or breathing studies we may have had pre-COVID and compare them to where the patient is now and make suppositions. This may very well be related to you having had COVID before. But beyond that, there's no testing that would tease out whether it's COVID induced or induced by something else. Now, mind you, if we have interstitial lung disease, it obligates us to do the workup to rule out a sundry of causes of interstitial lung disease, connective tissue disease, sarcoidosis, occupation exposures, and the like. But again, there's no biomarker that would tell us that it's specifically related to long COVID.
Excellent. We have, thank you. We have several questions coming in. Let me, this is a great question from one of our medical students. And greetings. As a MS3, I guess a medical student, year 3, currently completing my rotations at Hackensack, I'm curious about strategies to tackle disparities in sickle cell crisis management. What key initiatives or interventions do you consider vital for ensuring equitable care? Ensuring equitable care delivered in such instances. So that's
a tough question.
I'm so happy for this question.
Well,
so we got to be sharp on this one. So let's talk about sickle cell and delivery of care to people, to our people, and what's out there, and how should we be sensitive to that?
I think that the entire panel could probably weigh in at some level on this, and I would encourage them to do as well. From my perspective, I think that, Omar, you tipped this off at the beginning of this by saying that the intention for us all has to be to increase our presence in the medical field at every level, but most poignantly at the level of the provider, where we are the ones that are advocating for our patients. We are the ones that are directing our patients to experts in various arenas. We're the gatekeepers. And so we have to make a concerted effort to improve our numbers. As we're all aware, there's a paucity of historically Black medical schools nationwide. As it stands, there are 4, with 2 that are on the horizon. I sit on some committees at Howard University College of Medicine, and our difficulty is that even since I graduated from medical school in 1988, Howard has not been able to increase the number of matriculants through their medical school. They're capitated at the number of seats, and that's based on a number of different reasons, but predominantly based on the number of attendings that are on staff at Howard University Hospital to teach the students. So that's one area that on a national and statewide level, we need to advocate for more seats for African American students. Secondarily, when we look at the array and panoply of medical schools across the nation, even though there are substantially more medical school seats, the numbers of African Americans that are, and Africans for that matter, and Afro-Caribbeans that are matriculating to and graduating from medical school is no different now than it was in 1988. So that speaks to a need for us to not only increase the number of seats, but also have people in positions in these institutions to ensure that African Americans are getting those seats. And more importantly, we have to go down the trail of undergrad and high school and junior high school and elementary school to put the seeds in the minds of our children and our grandchildren that medicine is a viable and necessary and important career, and it's necessary for the viability and health and longevity of our people. So that's my take. I open the floor to others to weigh in on the specifics as it pertains to institutional work.
All right, Dr. Sprout, please.
So it's an interesting question. But I'll just tell you my perspective, because again, all the individuals that have sickle cell disease are born with it. And one of the issues is if they live long enough, they get to transition from being seen by pediatricians or pediatric specialists, and they have to go to adults. And there are not a whole lot of adult hematologists, oncologists that deal with hematology, and even fewer that may want to deal with a patient population that they're not as familiar with. And so that's a big issue. There's some care issues that are also extremely important. We talked about the issue of crisis. And indeed, when these cells start to sickle, the most common type of crisis is called a painful crisis. And so there's this whole issue of pain medication for sicklers. And there's a problem that occurs when individuals that have sickle cell disease have painful crisis, and they go to the emergency room, and the emergency room doctors don't want to give them enough pain medication to deal with their pain. They believe that they're being abused. And there are a lot of studies that show how most of the patients that have sickle cell disease do not use medications for pain. And if you think about the opioid epidemic, where people were getting OxyContin and Vicodin and you name it for almost no reason, the pharmaceutical companies, the doctors, the pharmacists, the distributors of these medications were making tremendous amounts of money, but that was a use or misuse that was occurring in a different patient population. And so there need to be people that number one, understand the issue and understand that the need for pain control is essential, and that it's not that these patients are abusing the pain medications, but they may need extremely high levels of pain medication to control their pain so that they can actually function. The other thing that can occur, is that and this becomes something for Trevor as well, but individuals that have chronic anemia, they have a decreased level of hemoglobin, therefore they have a decreased number of cells that can actually transport oxygen. And so what happens when you have a decreased amount of hemoglobin is your heart sort of accommodates for the anemia by enlarging. And what it does by enlarging is for each time that it contracts, it can send out a larger volume of blood. And that larger volume of blood may be sufficient to get enough oxygen to the tissue. But you have a situation where the blood volume, if you will, is sort of expanded because the heart has dilated. And so if an individual needs to have a transfusion that has sickle cell disease, you need to be extremely careful in how fast you transfuse these individuals. You can't transfuse them at the same rate because a small volume
transfusion. What are you talking about?
So there are certain situations where
you got to break some of these words down.
You need to give a patient that has sickle cell disease blood cells.
Yeah.
Okay, they may have a situation with the lungs, or they may have a situation with another organ where you need to give them blood that won't sickle.
Right.
And that blood comes from a transfusion from someone else.
Right.
But understand that their blood volume is somewhat expanded, but it's expanded by fluid, not red cells. Mm-hmm. So the number of red cells is less. And so in order to keep the volume within the blood vessels the same, you have an increased amount of fluid. And that fluid doesn't carry oxygen. So if you transfuse a sickler with a packed red blood cells that has cells that won't sickle, mm-hmm. you have to give them as slow as you can and maybe give half the volume over time, or else you can throw them into failure. And so if you don't quite understand that they have these big hearts, and if you give them too much blood, your treatment can throw them into heart failure and cause them to go into pulmonary edema. So if you need to have individuals that understand these kind of peculiarities, understand the pain issues related to them, and it's only done by people that are interested in taking care of them. Right. Unfortunately, people go into hematology oncology if they're an adult. The money isn't going to be in sickle cell. Mm-hmm. The money's going to be in oncology. Right. And finding individuals that specialize in hematology and not oncology to take care of a patient population that's relatively small and is related to people of color is extremely difficult.
Yeah.
And so, Dr. Kingslow, you're at Howard. I don't know if there's a large number of people that are at Howard that even specialize in hematology and take care of sicklers.
Mm-hmm. Yeah. They used to have a sickle cell center, but that's since closed, and their hematology department is anemic. Yeah. No pun intended.
Yeah.
And that's the problem. And so Omar, you hit it on the head, but there's certain specialties where if there's not a lot of money being made, mm-hmm. a lot of folks aren't going to go into them, and then the ability to care for them becomes tenuous.
Yeah. And I've heard many things. My wife's a pediatrician, and she talked about many things, and we have these discussions. And I've heard sicklers say that the doctor would come in and state that, you guys handle pain, meaning that you guys who are African American or of African descent handle pain better than other people, so I don't have to give you as much pain medicine because you're not really in that much pain. And statements like that is just. I think there needs to be so much more education as far as, listening to your patients, understanding what's truly happening to a patient, as opposed to coming in with a preconceived notion about a patient. Once you hear something, this diagnosis, okay, I walk in, I know exactly what's going to happen. I know what's going to, we can handle it this way because there's going to be a problem if they're going to be asking for meds. We really have to come to a point where physicians of all nationalities, because it's a good chance that sickler coming into the ER is not going to be serviced by another African American, and we need to try and educate as best we can those physicians out there who are taking care of people that would have this disease, that are more likely to have this disease. Dr. Court, please.
I really echo what was said recently, because I've had patients who would go to the emergency department, and I think the patients are stereotyped in terms of, they're just there to seek pain medication. And I don't know what to do in terms of this because we as doctors also, we can be flagged in terms of pain medications that we prescribe in terms of our license. Because if you check, most of the doctors who have been suspended is for narcotic prescriptions or inappropriate prescriptions. But it's a problem. I don't know how this can be solved nationally, because these patients truly must be in pain. But again, they're stereotyped. Well, you're just there for pain meds. Also, I was at Howard a few years before Dr. Kingslow, and I remember there used to be a doctor there that was doing research in terms of the genetics of sickle cell, in terms of the gene rearrangement. I don't know if that still goes on nationally or just been marginalized because of not too many people are interested in that. So does Dr. Kingslow know if this still goes on at Howard University? But you said that the center was closed.
Yeah, that sickle cell center at Howard is closed. Most of the work has been shifted over to National Institutes of Health. You may be referencing Dr. Scott, who was at
I think
Howard
that's the name,
when you
yes.
were there, and Dr. Castro, who
Yes.
was at Howard when you were there. Dr. Castro is still with us, but has retired. But he moved his practice from Howard probably 15 years ago, 18 years ago, over to NIH, and they're still doing pivotal work. I mean, we have, you now have bone marrow transplants, which has come to the fore over the last decade for curing sickle cell disease. And there's still breakthrough advances that are in progress and ongoing research in sickle cell disease. But as you're well aware, it's an African-American based disease. And in those arenas, money is often limited and short.
Yes, yes. Jordan, Dr. Garrison, you're up.
Once again, hey everyone. Trying to get back to the medical students question. Some of this has to do with the sociology of medicine, and both on the physician and the provider's part as well as the patient's part. I know doing surgery that in asking my patients about their pain tolerance and things like that, there is a certain feeling within our community that if you don't get high taking a drug, it's really not effective for pain management. And I've seen that over and over and over again. So there's an education piece that we have to talk to our patients about, especially in us giving pain medications. But also, what can we do? And I think Dr. Kingslow was talking about the statistics about African Americans going into medicine. One of the things that we're combating is the media and how the media has culturally appropriated things that are in our community and use that to advocate for their products. And one of the things is the music industry. One of the things is this life of joyous, happy, and free that is being thrown at our youngsters. I think, Dr. Kingslow, you come from a family of physicians and nurse practitioner and anesthesiologists and so forth and so on. That's how I said I knew you and knew the last name from those people. But I have two children, and when I asked them about going into medicine, they were like, thought I had asked them to swallow razor blades or something like that. And the thing about get rich quick, they say things like, whoa, I know in my training, it was 7 years of training after medical school and then an additional year of fellowship. That's a long time. And now it's about, can I make the money? What can I do? Can I make money? And we know that reimbursements are down. Physicians aren't making the millions that they seemingly used to make, or the perception was, and it's not the easy money. And our children it's being pushed at them. It's like there's this great lifestyle that you can have, and they're being pushed that the kids now, they don't stay in jobs long. They go from one job to the next, to the next, to the next. That is a lifestyle and a professional lifestyle that seems to be advocated right now. And medicine is anything but that. So somewhere we have to address and combat the social messages that our children are getting, because all of a sudden it seems like African Americans got money, they can spend money, and the things that were holding our community together now are being pushed at us in a different way. And so that has to be addressed as well.
I agree, Jordan. I agree. Very well said. Let me jump to some of these questions because we have quite a few questions come up. Is there a problem having too much vitamin D if you have sarcoidosis?
Excessive amounts of vitamin D can cause issues with your bone. There's hypervitamindosis that is a disease entity in and of itself. It's reasonable to measure your vitamin D if it's of concern. I always advocate for my patients to sun themselves, get out, take a walk, so they can naturally get vitamin D converted through their skin. And then every 6 months or so, I encourage them to get their vitamin D levels measured. We know that excessive levels of calcium in the body can potentiate issues and injury as it pertains to patients with sarcoidosis. We know that with sarcoid and the granulomatous formations, that calcium, hypercalcemia is a known comorbidity related to this disease. So excessive vitamin D can add to the potential of patients having hypercalcemia. Hypercalcemia portends lethargy, fatigue. It can induce cardiac aberrations, ileuses of the bowel, slowing of the bowel, constipation, and then as it advances, altered mentation and a loss of sensorium with the more extreme levels of the calcium. So I hope that answers the question.
Yeah. If I remember correctly, calcium is increased as far as absorption with sarcoid.
Yes.
So, and it can cause kidney stones and all of that type of stuff, and hypercalcemia. Hypercalcemia is rare, but it can cause that as well. Let me do this. Let's take our halftime break, and then we're going to come back and do some more questions, and we will continue after that. All right, let me get my act together here. All right. I'd like to let each doctor reintroduce themselves. Just a quick reintroduction. Dr. Court, please start off.
James Court, internal medicine. I practice in East Orange, New Jersey.
All righty. Dr. Kingslow, our guest, please.
Les Kingslow, pulmonary critical care, hail from Orange, New Jersey. My father practiced at East Orange General for 35 years.
I remember him.
Yes, thank you. I do too.
All righty. Dr. Court, please.
You did me right.
Oh, I'm sorry, Dr. Atherley. I'm sorry.
Yes, my name is Trevor Atherley. I'm an interventional cardiologist practicing in Essex County area in New Jersey, predominantly out of Newark Methodistville Medical Center.
All right. Dr. Sprott.
Kenny Sprott, pediatrician, did 15 years of pediatric critical care.
And Dr. Ali, I got a couple questions for you. You kind of went away on me there, and I was like, oh, ready to ask you, and you were gone. But please reintroduce.
Sorry, I'm back. Mazhar Ali, gastroenterologist at Scripps Clinic in San Diego. And just to throw in there, undergrads, actually did my medical school and undergrad work in DC as well at GW.
All right. Dr. Garrison.
Hi, Jordan Garrison, board certified general vascular and bariatric surgeon, presently doing diseases of the veins, and my office is located in Hackensack, New Jersey.
Excellent. And I'm Dr. Omar Bey, pulmonary critical care with a subspecialty in nutrition. Dr. Ali, I'm going to grab you just for a minute because we're talking about anemia all over the place. Sickle cell anemia, this type of anemia, that type of anemia. And you're a GI specialist. And, in the critical care setting, ICU, often patients come in with GI bleeds and anemia, and we have to figure that out if they going to surgery, or especially as far as the sickle cell is concerned. I don't know if you get into or you come in contact with sickle cell when you have to do procedures on them? And what are you thinking? How do you approach that?
So, one of the questions that comes to mind as somebody presents with anemia, right, is it related to a bleed, gastrointestinal bleed? And, when we think about anemia, there are different kinds. We talked about sickle cell, but there's also what we call an iron deficiency anemia, where your iron could be low. And the most common cause of iron deficiency anemia in this country is blood loss through the GI tract. Now, you wouldn't necessarily see that blood, right? Because sometimes that blood could be microscopic, meaning just a little bit comes out and you wouldn't see it mixed in the stool. Sometimes when we think about a GI bleed, we look at the toilet bowl and it could be red, or it could even be a dark black color, what we call melena, which is more of like a digested blood. But a lot of times if you don't necessarily see that. And if somebody presents with anemia or a low blood count, GI often gets called because the question comes to mind, well, let's just make sure there's not a bleed happening anywhere, right? And that could be from things like an ulcer. And especially when people are in the hospital or in the ICU, stress ulcers could be very common. And that could be like an ulcer of the stomach that could be bleeding. Sometimes this could be related to bleed related to like a blood vessel that's exposing itself out to the lumen or to the bowel itself. And we call that something called an arteriovenous malformation, which is essentially just a little blood vessel that makes its way out to that bowel, and it just bleeds a little bit. And sometimes, though, in some people, it could even bleed a lot, depending on the situation. And then, the other that we always think about is cancer. And that's why also, regardless if somebody may have another cause like sickle cell for an anemia, we want to make sure we're very up to date with our screening guidelines, and people get their colonoscopies, and that usually starts at the age of 45. And sometimes, depending if there's anemia, I also may want to do an upper endoscopy and also look inside the stomach, screen people for stomach cancers or any other potential reason why there could be an anemia.
Excellent, excellent. Anemias are something that's so common, and we as docs come in contact with it all the time. Hold on there, I got something. Okay, here we back. Come in contact with it all the time, especially in the ICU. It's something that happens all the time. So we use you guys as far as gastroenterologists, and we're calling you all the time for anemia. Let me do this. There's quite a few questions. Let me get some more questions done. This is one. Let me read this one. Do you have or have you seen the evidence that COVID shots itself has made people very ill, and essentially now realizing it should not have been given to man, meaning that it never should have been given to us? Can someone enlighten us as far as the COVID shot and the possibility that it is causing people to be sick as opposed to COVID virus?
So I think the literature is clear on this, as is the lay press, that vaccinations work. I've been on this earth for 61 years. I've never seen an active case of polio. I've had patients who had polio that contracted it as a child back in the 40s and 50s, but I've never seen an active case of polio. And the reason is because the polio vaccine works. I have never seen a case of tetanus. I've never seen a case of the measles in my adult life. And the reason why is because the bulk of the population has been vaccinated against these worldwide pathogens that for eons decimated mankind. As it pertains to the COVID vaccine, we've had well over 1 billion people worldwide vaccinated against COVID-19. If there was an epidemic of untoward effects related to the vaccine, it would have been common knowledge now that we're a few years into being vaccinated. What we appreciate with the vaccine is the similar discomforts that we appreciate when we mount an immune response to anything. That being a little discomfort at the injection site, a little achiness, maybe even a low-grade temperature, and typically that dissipates within 24 to 48 hours. We do know that patients can have arthritis reactions to vaccinations, in which an arthritis reaction is marked swelling and irritation and redness at the vaccination site that may last for a number of days and is typically limited and controlled with analgesics. And we recognize that in the literature that there's a smattering of reports of patients, particularly younger patients who've received the vaccine, who've sustained myocarditis, an inflammation of the myocardium. But this is extremely rare. I have not run across it in my patient population. In reviewing the data in the greater Washington area early on through the early portions of the vaccination course, we didn't have any spikes in myocarditis. And my understanding is that it's pretty much a single digit disease state as it pertains to this vaccine. I believe that, and I have no vested interest in the vaccine beyond the fact that it reduces the disease state and improves survival. But my sensibility, and I think the literature supports this, the vaccine is safe, it's necessary, and it has prevented disease and will continue it has reduced disease risk, prevented the spread of disease, and reduced the morbidity and mortality as it pertains to this disease.
Excellent, excellent. Dr. Court, please.
Of course, vaccines work. Look at the state of New Jersey. In 2020, how many people were dying each day? The vaccine came in December, I think December 21st. And since then, there's been a dramatic decrease in terms of the number of deaths. Even in my own practice, I lost 30-something patients in 2020. The next year, there were only 10. And the third year, only 3. What was the game changer? Was no question about it, is the vaccine. And the reactions that patients complain about, that's the way your body responds. It's the immune response. It tells you that the vaccine, at least it has recognized that this is COVID or a part of COVID, because we don't put COVID or any parts into the patient's body. So it works.
Yeah.
Show me the evidence that it does.
I agree 100%, Dr. Court. In the ICU at this particular point in the hospitals, we've seen a spike of COVID actually over the last, I'd say, month and a half or 2 months. And the amount of patients that come to the ICU because of COVID are very few. And most patients, even though they're admitted to the hospital, are released and go home and are doing fine. So and I should also say most of those patients have had the vaccine. We still get occasionally a patient that comes in without the vaccine, and we're very fearful that they will have as far as more morbidity or even possibly mortality because of the that particular disease of COVID. Dr. Court, you have your hand still up, but
Oh, sorry.
you answer.
I'm done.
Okay, Dr. Sprott, please.
I think it's important that when we use words, we kind of understand what the words mean or what they don't mean. And when individuals talk about evidence, the whole issue of what is evidence-based and where the evidence comes from is important. I think that there's today, very different than 20 years ago, the social media and things that get spoken as if they're true, like elections and vaccines and other things, may not have any evidence related to what's being stated. And people tend to not think about the truth as being the actual truth anymore. And so I think that people need to be critical of what they see, what they hear, and what they read, and where it's coming from. You know, there are a lot of individuals who've made a lot of money by spreading rumors and lies. And it creates a lot of confusion. And it becomes extremely important. As I said before, I spent 15 years doing pediatric critical care. And, when I first started pediatrics, there were a number of vaccines, but not nearly as they are now. But we used to see deaths, kids losing limbs from meningococcemia, meningococcal disease, pneumococcus, H influenza, especially H influenza and pneumococcus and sicklers used to be the major cause of death in the first 2 years of life. Once we developed these vaccines, it disappeared. We're now seeing outbreaks, and this issue of herd immunity, where most of the individuals that aren't vaccinated are protected by the 95% of individuals that have been vaccinated, and you don't see it. But once you reach a critical point where the number of vaccinations starts to decline, you start to see it. It's happened a number of times in New York, where there are a number of large individuals who use, I'll say, the excuse of religion to not get vaccines when there's nothing in the Bible or the Quran or the Torah that talks about not using vaccines because they weren't around it. But people use these as a reason for not doing it and not getting it. And, we still have laws in New Jersey that require that kids be fully immunized before they go, unless there's a medical indication for them not to get a vaccine. And there are a few individuals that have immunocompromised. We were specifically concerned, but even in HIV, when HIV was rampant in pediatrics, about the issue of whether or not they should get protected by vaccine versus the risk of getting the vaccine because they have the immunocompromised. And it becomes a judgment call. But many people look to talk about evidence based upon something that they read by someone that didn't have any evidence about what they printed or what they said or what they put on a podcast. So people need to think critically about what it is they read and from whence it's coming.
Mm-hmm. Mm-hmm. Excellent.
I had a mentor always tell me life is a struggle against bad data, right? Bad input is bad output. And when we look at the data on how these vaccines were studied, right, they were used with very high quality evidence. And we had a regulatory body that utilized that evidence to approve this in a very methodical way, right, using the adequate amount of literature. So whenever we see papers out there, it's not just any paper that says, oh, well, this is the reason why it's approved, and that's it. We have to really critically appraise that research. And I believe that in the setting of this scenario with COVID and these vaccines, the data has been strong, and it really has shown that it's beneficial with good evidence. So, we always have friends and colleagues and patients that may say, oh, I have a friend that said this or that, and I read this paper, but not every paper is a valid and legitimate paper.
True. Dr. Garrison, please.
Just to take it on a little bit of a different tangent about vaccines, about the economic input of being vaccinated or not vaccinated. And I'm just going from the surgical literature. Our healthcare costs are about 10% of our GNP. Of that 10%, 5% of that healthcare goes to wound care and obesity-related diseases. Now, when people are not, and that comes out to about $20 billion a month, okay? And so when people are not vaccinated, the amount of people that end up in the hospital, it delays all elective surgeries, all these surgeries that are necessary to bring people to definitive treatment of their wound care, ulcers, and diabetic-related wound infections because of the obesity or the venous insufficiency. So if I'm delaying this care for 1 month, 2 months, 3 months, because these people can't have their surgeries, it is putting a tremendous burden on the economic systems and the increase of the cost of healthcare. So not only does it save lives, but it prevents, by people getting vaccinated, it prevents these downstream products such as the wound care and the obesity-related treatments, and it increases those costs.
Excellent, excellent. Let's go.
I'd like to throw in a little bit just to agree with most of what has been said, and to look at the slant that Dr. Garrison has shown. Very important. I'd like to say, however, that the more dangerous aspect of these misunderstandings about vaccines is not the absence of benefit or the absence of some damage caused by vaccines. And sure enough, there have been some papers that have shown some ill effects of the vaccines. But one should be able to have the perspective of looking overall at the broader picture and seeing the great good that's come from the vaccines, so that one could use that in negating some of those papers and some of the articles which do purport to show, some of them factually and many exaggerated, ill effects that have been brought to the surface as a consequence of the vaccines. So the perspective is important, not merely the facts, but a proper appraisal of the facts and the ability to appraise these properly. And maybe that is our job and our task in trying to bring to the forefront the not just the reality, but the proper interpretation of things that we see out there scientifically shown.
Excellent, excellent. Let's go to another question, because we have them mounting up here. These questions are pertaining COPD. COPD. What causes the yellow mucus that looks like you have when you develop a cold? They say that's number one. And let me do both of them here. Stage one simply. Does the disease cause the legs to swell, or cause the person to experience extreme tiredness? And they're talking about COPD.
All right. So for the yellow mucus, the yellow mucus can be caused by a couple of things. One, we know that COPD is an inflammatory disease. In the setting of an inflammatory disease of the airways, there's an increased production of goblet cells, formation of more goblet cells in the airways. These are cells that release mucus into the airway. In the setting of an inflammatory disease, if the inflammatory disease is triggered by ambient allergens, environmental allergens, and we see that in a percentage of patients with COPD, there's an influx of a certain type of cell called the mast cell, M-A-S-T cell. And these cells can populate the airways and secretions exponentially. And these cells give the mucus a yellow discoloration. So that may be one of the reasons why the mucus is yellow in the setting of COPD. But the more ominous reason why the mucus is yellow is probably because with chronic obstructive lung disease, its first cousin is chronic bronchitis. And that is inflammation of the bronchial tubes, in which the patient is producing yellow, green, brown mucus for 3 months out of every 12 months of the year. That's the definition. And you can also have an increased propensity for acute bronchitis, which is what you think of as the common cold. And the mucus in these instances can and will be yellow, green, brown, sometimes blood-streaked. And in this setting, it's imperative that the provider, the clinician, consider chronic bronchitis as a player in these patients and treat it, and treat for those common pathogens that affect patients with injured lungs. H. flu, pneumococcus, mycoplasma, these are at the top of the list. And there's an array of antibiotics that can be directed against this. If an empiric course of antibiotics doesn't alleviate the yellow-green mucus, then it's probably important to get a chest X-ray with considerations for a CT of the chest to get a three-dimensional view of what the lung tissue is looking like. In addition, patients who have chronic lung injury can develop bronchiectasis, which is dilation of the bronchial tubes, flabbiness of the bronchial tubes, and the normal immune apparatus that helps protect us from germs setting up shop in the airways is inadequate. And these patients also will develop chronic and unrelenting discolored mucus. And that diagnosis is teased out by a look at the lung tissue with a three-dimensional view via a CAT scan.
Right, CAT scan. Excellent. Dr. Sprott, you got a question?
Yeah, I think that one of the things way back in the day when we used to do laboratory work in our practices is to look at the mucoid secretions. You know, mucus comes from mucus glands, and we have mucous membranes that line the eye and line the nose and the throat and other areas. And so one of the things that can add to the thickness and the color is the presence of white cells. Viral infections are usually the most common types of infections, especially upper respiratory tract. And what tends to happen is, again, they invade the cells, but the response to that viral infection is usually a release of white blood cells, usually lymphocytes, a particular type of white blood cell, to help fight those infections. And so what you'll start to see is that someone starts out with sort of clear secretions from the nose, and then it starts to get thick as the white cells start to come in. Now, we used to do some slides and some gram stains and to see whether or not there are presence of lots of bacteria and the different types of bacteria that are there. With a bacterial type of infection, the cells might start out as lymphocytes, but then they become predominantly related to neutrophils. And you can sometimes see this trend when you do complete blood counts, where you look at the type of white cells that might be present, if they are elevated, and if they're predominantly lymphocytes, which would mean a viral infection, or predominantly bacterial infections where there'll be neutrophils. But the presence or the absence of those white cells will help make a distinction as to whether or not it's an infectious process or not. And this has nothing to do with COPD. It just happens to deal with the regular types of infections. The same thing starts to happen with the other infections that are around there. There's sinus spaces that surround the nose that are filled with air. Sometimes when these openings get blocked, they start to accumulate with mucus, and bacteria there starts to grow in them. The same thing happens behind the eardrum. Fluid starts to accumulate. If this fluid stays there long enough, white blood cells start to get in there and start to change and make it thick and like pus. And so you start to see that these mucoid secretions start to become more pus-like if you're talking about infectious processes. And then you're talking about the possibility of using antibiotics if it's bacterial, or just wait and see if it's viral.
Can I piggyback on that? And Dr. Sprout, you're absolutely correct. I did fail to mention the necessity of getting cultures on secretions. We do have rapid tests to do swabs to look for strep antigens, Legionella antigens, and we can always do sputums for gram stain and culture. And in our day, we were doing those ourselves, but nowadays it's hard to even find a lab who's willing to run a sputum given a patient who's actively ill with an upper respiratory tract infection.
Right. Dr. Kinslow, I want to cover something that I feel we must cover before the webinar is over. Sarcoid. Can you give us just an idea of where we are? And it doesn't have to be abroad, but just from a basic standpoint, so the public can understand where we are with sarcoid and what is sarcoid. I mean, you know, I as well as you been treating sarcoid for many years, and there's a lot we don't know about it, but so many of our patients have it of African American descent. I think we wouldn't do justice if we didn't cover that. Can you start us off with it?
Well, you hit the nail on the head. There's so much about sarcoid that we really don't know, unfortunately. This is a disease in which the body recognizes another part of the body as being foreign. It's an inflammatory state. Now, anytime we have inflammation, say for instance, we have a low-grade splinter in our finger and the finger is inflamed, the body will send cells to that area of inflammation to try to heal that inflammation. Those cells are predominantly macrophages. If the body can't heal that inflammation, say for instance, that splinter as the example, the body is then going to try to form a wall around that inflammation, around that splinter. So it aggregates all these macrophages to that area, and then it surrounds it with other inflammatory cells to try to wall that area off. and that wall is called a granuloma. Sarcoid is made up of granulomas throughout the body, and they form because the body's recognizing a portion of the body as being foreign and developing an inflammatory reaction around that recognized foreign portion of the body. We don't know of any specific antigens that have been identified as a culprit for sarcoid. We used to think it was a cousin of tuberculosis. It's not. We used to think that it was some type of a virus. It's not been identified. It's not a malignancy. It's an inflammatory autoimmune disease that causes inflammation through the body. We recognize that there's an increased propensity among families, siblings, twins, mothers to children, and there's about a 10% incidence among families of sarcoid being present. We see that it's exponentially greater in people within the African diaspora. That includes people in the Mediterranean region. It includes people in the Caribbean. It includes Dominicans and Puerto Ricans and Costa Ricans and Venezuelans. And we see it, the incidence is probably about 1 out of every 10,000 lives in the United States. The organs that are affected most predominantly with sarcoid are the lymphatics. And we have glands everywhere. We have glands in our brain, glands in our skin, glands in our eyes, glands in our mouth. Everywhere there's glands, and those glands can be involved with sarcoid. There's no treatment for the glandular involvement with sarcoid. But when these glands get significantly inflamed and start forming these granulomas also form in the tissues of these organs. The next most common organ that's involved is the lung. And we form granulomas in the lung that present themselves as nodules. And they as the disease progresses, it presents itself as what we call interstitial markings or lines within the lung tissue. And those lines do not exchange the good air for the bad air. And as the disease progresses further, it forms scarring of the lungs, where the lung has now lost its resilience and its compliance to be able to do its work, which is exchange the good air for the bad air. There's different stages of sarcoid. The majority of patients who have sarcoid, it's very indolent. It typically goes into remission. Most patients, 70% of patients, don't even have to worry about it. They live their life with it with no issues. That other 30%, 20% of those people typically will have a waxing and waning course where they'll have exacerbations of their sarcoid that may quell spontaneously or may require medications to quell it. And those exacerbations are manifested by shortness of breath, coughing, phlegm production, fatigue. And then there's that last 10%. And these are the patients that have the most active form of the disease. It's progressive, it's debilitating, it's multi-organ involving, and it's oftentimes deadly. Sarcoid can involve other organs in addition to the lungs. We see cardiac sarcoid, we see hepatic liver sarcoid, we see kidney sarcoid, and more commonly than those others, we see skin sarcoid, where we'll see nodules about the skin, oftentimes at the lacrimal glands, around the nose, around the lips, and we'll see these hyperpigmented, bluish, reddish lesions of the skin and nodules about scars. Tattoos, old injuries where there's skin scars, you'll see the sarcoid presenting itself. In my practice, I have the whole panoply of patients with different forms of the disease. The majority of them, it's benign. We see patients with glands that are involved in the chest. There's no treatment for that. Those patients who have interstitial lung disease, depending on how they're progressing, we may give them a course of immune suppressants, corticosteroids, or alternatives, understanding the potential morbidity that these medications may portend. There's no medications that have been shown to improve survival, unfortunately, as it pertains to treating the lung disease. The only thing that's been shown to improve survival is lung transplantation and supplemental oxygen. There are comorbid diseases that walk hand in hand with sarcoid, and one is pulmonary hypertension secondary to sarcoid. And this is a disease that's important in that It causes a lot of untoward effects as it pertains to these patients, and it's often under-recognized and overlooked. So when patients present to me with sarcoid, on my first list of things I do, in addition to the breathing studies, the PFTs and the CAT scan, is getting a screening echocardiogram to look to see if the right ventricle is functioning efficiently. And even if the right ventricle looks okay, whether there's evidence of tricuspid regurgitation, because if I see those changes, then it cues me to think, well, maybe this patient has sarcoid-induced pulmonary hypertension, and the workup is warranted in that regard. Suffice it to say that the best thing that a sarcoid patient can do is, one, find a doctor who has an interest in this arena. Two, go to the gym, exercise, get in the best shape that you possibly can so that you can be prepared for any downturn that may arise. If you're overweight, lose the weight, because there's a good potential that you're going to have to go on steroids sometime in your lifetime. So you want to tune your body to be prepared for that. And lastly, make sure you're up to date with all your vaccinations, because you're at high, if you have interstitial lung disease or lung parenchymal injury, you're at a high risk for more untoward effects or sequelae if you contract one of the lung-inducing diseases that we have vaccines against.
Yeah, excellent coverage of I've go ahead.
Of the concept of sarcoid affecting the heart. There are a couple of arenas, a couple of areas in which it may affect the heart, and some have been alluded to. Certainly the secondary effect of pulmonary hypertension, that is, if it increases the pressure that the arteries that go to the lungs meet, the pulmonary arteries, then this can be reflected in causing failure of the right side of the heart, as opposed to the left side, the right side. And there are many manifestations of that I really will not go into in detail. But in involving the heart as a whole, there are two areas that we look at specifically for the more direct effect on the heart. One is the deposit of the sarcoid granuloma into the muscle itself. There are certain select areas of the muscle that may be involved, and these may cause failure of the overall function of the heart. As you recall, the heart's basic function is as a muscular pump. Therefore, failing to pump properly may allow untoward accumulation of fluid in the lungs, et cetera, et cetera. So there are many consequences there. The other area that I want to highlight is the conduction system. Now, in order to function adequately as a pump, the muscle receives signals which travel via nerves. You have certain specialized nerve systems within the heart which carry the electrical activity to tell and to prompt the muscle, it's your turn to contract now, et cetera, et cetera. Therefore, deposit in these nerves may affect the conduction system such that the information is not appropriately received to certain parts of the muscle, and one can get a variety of partial or even complete blockage of the conduction system, heart blocks. So these are the two areas that I see, although I don't see sarcoid of the heart as a very frequent manifestation. These are some of the more serious ones that we look out for in terms of cardiac involvement.
Excellent.
So I also see some GI manifestations. It's very rare, but we could see sometimes sarcoid involve the liver. And what it could look like is just kind of a nodular appearing liver. And the way we would usually diagnose it is by biopsy, finding these granulomas in the liver tissue. I've actually seen it once in the stomach as well. It can involve any part of the GI tract, but very rare. And it's actually one of the mimickers that we have if something called Crohn's disease, which is another autoimmune-based disease of the GI system. This is one of what we call the mimickers, and it could look like it, but again, much less common. My question for Dr. Kingslow, is there a role here in terms of treatment for beyond prednisone, or if somebody requires prednisone more than just a couple of times a year, more longer standing immuno-based therapies? In my world in GI, we use a lot of biologic therapies like Humira or Remicade. Is this used often, or could this be used as well in this arena?
So there's no biologics that are available to date for the management of sarcoid. We do use alternative immunosuppressants. given the understanding that prednisone long-term is just so brutal on the body and increases our risk for a multitude of complications. So my practice is typically to try to quell patients down with their inflammatory disease of their lungs with a course of steroids, and then look to alternatives. And they might include Plaquenil, hydroxychloroquine, methotrexate, or Cellcept. I use a lot of Cellcept in my practice. Patients who have disfiguring sarcoid involving their eyes and their lacrimal glands, I've used rituximab in that population with great success. But our cadre of medications available are quite limited, and none of them are without the potential of a sundry of side effects.
Yeah, just to piggyback on that, Dr. Kingslow, I feel that at one time I probably had one of the largest populations of sarcoid in New Jersey.
I've sent you some of mine, actually.
I remember. And, one of the medications I've tried, obviously, methotrexate. I didn't think methotrexate actually gave me a good response.
Yeah.
The one that I liked the best was Cellcept.
Yeah.
I shouldn't say because I have several patients on it now even, and that seemed to respond. The sarcoid seemed to respond to that better than the other medications that we use as a second line medication for as opposed to the prednisone.
Yeah, the difficulty is, and as we all can appreciate, we have to get clearance from the insurance and go through, these specialty pharmacies for many of our medications nowadays, and mycophenolate being one of them, Cellcept being one of them. But yes, my experience is identical, that I find that Cellcept seems to be, one, a lot more gentle on the patient, and two, I seem to get a more robust effect than with those others that I mentioned.
True. All righty. There's some other questions. Let's grab these real quick. This says, Dr. Kingslow, is there an association between reactive airway disease and long COVID?
So we recognize
hyperreactive airway disease.
So same thing. Yes. So we recognize that in the setting of long COVID, we're unmasking a lot of asthma that we weren't seeing before. Is it that the patient had asthma before, and because of the insult from COVID, the asthma is now showing itself? Or is it that because of COVID, they're now hypersensitive? I don't know which one that is, but we do see more asthma in this population. Yes.
All righty. There's another question that came up briefly. What about Sjogren's disease? Now, I'm not sure what they're referring to or what they're putting it in there, but that was the question.
So Sjogren's is a connective tissue disease that can afflict multiple organ systems. In the pulmonary arena, it can induce injury to the lung parenchyma, interstitial lung disease, and pulmonary fibrosis. It's also part of that cadre of diseases that cause pulmonary arterial hypertension, hypertrophy, and vascular constriction of the pulmonary artery. So in any patient who presents to me with any clinical findings to suggest an autoimmune disease, a connective tissue disease, I screen them for the whole array of diseases in that entity, Sjogren's being one of them. If I find that they do have a connective tissue disease, then I'm doing a workup to assess the gravity of its influence on their lung parenchyma as well as their pulmonary vascular bed. I'm referring them into some sort of exercise training program, understanding that there's the potential risk for arthropathies and muscle loss in this population, and we want to address that as early as possible and get them to become athletes early on in the process so that we can extend their life and improve their quality of life through that.
Excellent. There's a question that came up. It says, my son has asthma and is on a nebulizer medication and occasionally needs prednisone. I hear that it is possible to grow out of asthma. Is this true? All right.
So our lungs continue to grow from in utero through our early adulthood, and our chest cavity grows through that, and with that, we can see a drop off in the severity of our asthma as our chest cavity grows. So people can outgrow the acuity of their asthma. However, once you have asthma, you always have asthma. Asthma is never going to go away. There's two peaks of onset of asthma. One peak is in the second decade of life. The second peak is in the fifth decade of life. And it's not uncommon that people will present to me in their 50s and ask me, why the heck do I have asthma now? I said, well, you're coming in right on schedule. So yeah, you can get better with your asthma as you grow, but you're always going to have asthma. And that takes me back to the same thing. Asthmatic children need to be active and exercise. I used to use the example of Flojo, the world-class track star who was a bad asthmatic. Her asthma would have been a whole lot worse if she wasn't a track star. So I always encourage my patients to train and exercise so that they can improve their musculature about their chest, improve their diaphragmatic function. My father, I had asthma as a child. My father, interestingly, a family practitioner in East Orange and Orange, he gave me a trumpet when I was 6 years of age because he knew that was going to help improve my lung compliance. And with that, my asthma improved as I got older, and I didn't have problems with asthma until I got into my mid-50s. So there you have it.
You know, I remember back in the day, my mentor used to say asthma was a bimodal disease. And what he meant by that is usually, you know, youngsters would have a flare of their asthma, and somewhere late teens, early 20s, it may, you know, not go away, but it would taper. It would dissipate, right? But watch out when you get 40 or 50, it's coming back on you again. So yeah, bimodal disease.
That just happened to me.
That just I got you. Dr. Sprott, I know asthma is something that you know that's a part of pediatrics, 110%. I remember back in the day, Dr. Rice and I used to go to daycare centers and lecture to the moms about their kids as far as asthma is concerned and how to, you know, to care for their children, their small kids. Do you have anything to say about asthma? Because it's a problem.
Asthma is a chronic lung disease, and in small children, there's this relationship between allergy, asthma, and eczema. And eczema is a condition where babies have dry skin, and they can sometimes develop these rashes behind the ears or in the creases of their joints. And if you see that a baby has eczema, it increases the risk of them having allergies, and it also increases their risk of having asthma. Another important thing that, and maybe Dr. Kinslow, you can help me understand a little bit better, is respiratory syncytial virus. RSV is a very, very important viral infection that occurs and significant for hospitalizations in children under the age of 2, but has a strong relationship from them developing lower airway disease from the RSV and then going to have asthma or reactive airway disease where they start to wheeze. The most common triggers of asthma in children are allergies and viral infections. And so we would always tell the parents, if they have a viral infection, look out for them to start to have wheezing. And we try and have them have asthma action programs so they can identify what things might trigger the asthma. Some individuals might have the asthma triggered by exposure to cold air or by exercise. But again, the common ones are allergies, and very often food allergies can trigger it, but also allergens that are in the air or things like tobacco smoke or dust and mold, or things like that. And so the issue is that what happens with asthma is that the airways, especially the smaller airways, get smaller. And if you think about when you normally breathe air in, you generate negative pressure within your thoracic cavity, and air comes in passively. It comes in passively because the airways within the thorax get bigger. But in order for the air to come out of your lungs, your rib cage starts to compress and causes the airways to get smaller. So usually what happens is when people breathe in, the air gets in okay, but if the airways get smaller when they're breathing out, when they exhale, that's when it starts to tighten. It can actually close off and you can develop air trap. But that's when you hear the wheezing primarily when they are breathing out. And so we used to say that if you have wheezing when you're breathing out, and that's the only time that you have it, that's not so bad. But if you're wheezing when you're breathing out, and then you're also wheezing when you're breathing in, that's a really bad sign and you need to get some help. So we developed these asthma action programs that basically have the parents understand what the symptoms are and how they can demonstrate that they're getting worse. And then they can add different medications, either a bronchodilator like albuterol or combination with a steroid, inhaled steroid, to try and keep their airways open. It's just like anything else. If you can reverse an asthma attack early on, it's a lot easier to reverse it than if you wait until they're very, very sick, they're starting to wheeze, they're starting to have difficulty. It becomes a lot more difficult for them to reverse it. So what we try and do is to get them to understand, especially if the children are old enough. We have these peak flow meters where they can blow through this device, and you can actually do that when they are healthy and see when they have their best peak flows. And if they develop a cold, even before they wheeze or they have symptoms, you can have them do the peak flow meter, and you can see that the peak flow meter is starting to show that it's starting to get worse. You can give the medication, get it back up to normal. So peak flow meters are very, very simple. They're simple devices that if the kid is old enough and they can blow out when they're supposed to, it's a nice thing to have, and to have individuals predict when they're going to get worse before they're actually symptomatic with wheezing and maybe can reverse it.
Excellent.
I'd like to piggyback on that if I could.
You
Excellent
always
points.
piggyback it on me, Leslie.
Yeah, because you're making me think more about other things I didn't touch on. But those are excellent points. One thing that I think the lay audience needs to recognize, and I find this in my practice quite often, is that when patients present, they are recalcitrant to the idea of using inhaled corticosteroids. We need to understand that asthma is a disease, first, of inflammation, second, of bronchospasm. The bronchospasm is in reaction to the inflammation. And the bronchodilators, the albuterols or the ipratropiums, these only treat the muscle spasm of the airway. They do nothing for the inflammation. And we have to impress upon the patients and their loved ones that there's a vital role for inhaled corticosteroids to maintaining a correct milieu in the lung environment and reducing those inflammatory responses to the allergens. Secondly, Dr. Sprout pointed out the importance of recognizing how essential to the pathology of this disease allergens are. And it's essential for the patients and their loved ones to know what's triggering the patient. And getting allergy testing is vital. We do a lot of allergy testing in our office. We do serologic testing. And there's reasons behind that. One, it helps us to counsel the patient, to educate them as to how to avoid, what triggers to avoid and how to avoid them. And secondly, there's a whole relatively new body of medicines that are available in this arena that weren't available 15 years ago. And those are biologics of asthma. And these are synthetic agents that help to block the cascade of the immune response that triggers the allergic reaction in asthma. And we now have 5 medications, all of which are injectables for the management of this disease. And they've really been game changers in that patients who I was seeing every 2 weeks for asthma and who were missing 3 months of work because of their asthma are now back to work. They don't have to see me as often. They're not having to take as many systemic steroids, let alone their inhaled steroids, and their quality of life has improved exponentially. And those are considerations, particularly with those patients who have brittle asthma. These medications are safe. They've been available for over a decade now, and they've been well recognized in their means to improve lung compliance as it pertains to asthma.
Yeah.
The other thing I like to tell the parents about the inhaled steroids is that if you think about it, the steroids are acting topically, so they are breathed in and they affect the airways topically. And the amount of steroids, the dosage is a fraction of the amount that they would need to take if they were taking it by mouth.
Right.
And so there might be a slight chance of some of the inhaled steroid getting absorbed and getting into the blood, but not nearly as high as it would be if they were taking it by mouth. And the idea would be for them to take it. And there, you know, with a lot of these medications, there are 3 different doses of the inhaled steroid that you can take, increasing it as it's needed. But even at the higher strengths, it's a small fraction of what might be taken orally to try and, again, because you don't want the steroids to be all over the body when it's just affecting your airways.
Yeah, yeah. Dr. Sprock, I usually tell my patients when you take prednisone, it's absorbed into the stomach, through the stomach, and that means every cell of the body is exposed. And when you take an inhaled steroid, 3 to 5% of that steroid gets to the systemic system, the rest of the body. Most of it works right locally at the airway level. And that's so important that they understand that how different the exposure is for steroid with the inhaled as opposed to taking it orally. Yes.
Leslie, you didn't talk about the expense of those biologics.
Oh, they're quite expensive, and hence you have to have good insurance, or you have to be in a city that or state that has good Medicaid.
Right.
It's a lot of paperwork at my end to get these things accomplished. But
Yeah.
even with Medicaid, I'm able to get patients. They recognize that this is a health burden on the system. Patients coming in and out of the hospital all the time, having to go in the ICU. If we can save one ICU stay, it makes it all worthwhile. Just one stay in the hospital is worth 1 year's worth of these medications.
Beautiful, beautiful. We're running over just a little bit, and I trust that you'll bear with me. We really didn't cover a COPD, and I'd just like to, just touch on that, at least what's the difference between bronchitis and emphysema and the association that it has with smoking and quitting smoking. If you could just get into that, and we'll talk about it, and from there we'll let that be the last topic.
Okay, so bronchitis is inflammation of the bronchial tubes. Chronic obstructive pulmonary disease is a disease in which the connective tissue of the lung parenchyma has become destroyed irreversibly, and causing, if you think of the air sacs of the lung as a collection of grapes that are the insides of the grapes are empty, the only thing you have left is the wall of the grape. That wall is where the oxygen goes across into the bloodstream and the carbon dioxide comes back into the air sac and we exhale it. So as we destroy the walls between those grapes form and coalesce into these large sacs. They're called bullae or balloons of the lung. And these sacs no longer are able to exchange the good air for the bad air. So the more that we destroy, the more loss of lung that we have. So all of us, we start losing lung. Our lungs start declining around the age of 35. We all begin to lose function at 35. If you add to that ongoing inflammation induced by chemicals that you're inhaling that causes emphysema, our lung function drops off exponentially faster. So it's important that we not inhale carbon. If the divine maker wanted us to inhale burning objects, it would have been burning on the branch for us to just pick and suck. We're not supposed to breathe anything but clean air. The lungs aren't built to manage water. They're not built to manage dirt. They're not built to manage dust, and they're not built to manage carbon. So when we burn a cigarette or we burn a joint, we're burning carbon. In addition to that, Philip Morris puts about 700 different chemicals into that tobacco that they process. So we're burning, not only are we burning carbon, but we're burning arsenic, we're burning formaldehyde, we're burning cadmium, we're burning benzene. All these are heavy metals that are toxic to the lungs, and they cause destruction of the lung tissue. And not only that, but they cause mutation of the cells as they replicate in the lungs, increasing our risk for not only emphysema, but also lung cancer. So it's important that we not smoke tobacco, we not smoke cigarettes, we not smoke marijuana, we not inhale vaping, we not go into dusty rooms and inhale the dust, because all of those are pathogens to the lung tissue. Emphysema is a progressive disease. We lose function as we age. We smoke more, we lose function more rapidly. There is no way to reverse that loss of function. We use these inhaled medications to decrease the spasm of the airway and decrease the inflammation of the airway. None of the inhaled medications have been shown to improve survival, although the long-acting muscarinic antagonists have shown a trend toward improved survival. The only things that have been shown to improve survival with emphysema are oxygen, ventilation, either via BiPAP or endotracheal intubation and mechanical ventilation, and lung transplantation or lung volume reduction surgery, which is a whole different lung volume reduction, either via surgery or bronchial valves. For the management of this disease, never smoke. If you do smoke, stop smoking. If you can't stop cold turkey, use nicotine supplements. You can put patches all over your body if need be. Nicotine doesn't cause cancer. It doesn't cause emphysema. It just gets you addicted. And then you want to make sure that you're vaccinated. You want to curtail your exposure to disease. Wash your hands. If someone's sick, tell them to stay away. Screen yourself if you get sick. Make sure that if you do have a bacteria or a virus, you get on it early and get treated for it, and stay in good touch with your provider. Rehabilitation is essential. Exercise is essential in patients who have any type of lung disease, COPD included. So I use a lot of pulmonary rehab in my practice. That is rehabilitation that's specifically geared toward pulmonary patients. Your insurance will pay for it. It'll pay for 36 visits, and it'll pay for it every other year. So once you graduate, come back a year and a half later, and you'll get right back into the program. And this has been shown to improve well-being, improve quality of life, improve musculature, and reduce exacerbations. Exercise.
You know, there's one more aspect that, oh, Dr. Court, go ahead. I'm sorry.
Can the doctor comment on whether vaping can cause lung damage? Just real quick, yes or no?
Whether, I'm sorry, vaping. Oh,
Vaping,
thank you very
yes.
much. Yeah, there's a sizable body of literature as it pertains to vaping and vaping-induced lung disease. There's an acute scenario of VAPLI, V-A-P-L-I, vaping-induced lung disease. And this is an interstitial lung disease that it's a non-cardiogenic pulmonary edema that can induce acute respiratory failure. And we've seen a cadre of patients with that. And it was lead article in the New England Journal of Medicine, maybe about 5 years pre-COVID, discussing this population. But in addition to that, the products that is used in vaping are not FDA regulated. So these companies can put whatever they want in them. Now, we know that in cigarettes, there's a ton of heavy metals already spliced into the tobacco. In vaping, when they looked at these chemicals, those same heavy metals are now 5-fold, 6-fold in the vaping pens. So there's even more exponential risk that long-term vaping may induce on potentiating lung injury and potentially lung cancer. There aren't any studies to date reflecting vaping and lung cancer, but it speaks for itself. If you got 5-fold greater amounts of heavy metals in the product, the likelihood that you're going to get lung cancer with it is great. Now, there is literature in which vaping has been used to help people bridge from tobacco abuse, cigarettes, cigars, to no tobacco use. And it looks favorable that if patients are able to vape as a bridge to coming off, then it's encouraged. And I have a number of patients who've done that successfully. The problem is that some people switch from cigarettes to vaping, and that opens its own long-term vaping, and that opens up its own can of worms for potential morbidity and mortality long-term. Hope that answered your question.
Yeah.
Yes, it did.
Yeah, you know, the thing of it is, and I think we'll end with this, is bronchitis. Understand that COPD is an umbrella term, and it includes emphysema, which is only probably about 20% of lung. And everyone thinks emphysema is the big action, but bronchitis and the fibrosis that is secondary and the restrictive lung disease secondary to ongoing and recurrent bronchitis is more notable as well as far as numbers are concerned than even the emphysema. But note that both of those can be devastating as far as destroying the lung and the function of the lung and requiring oxygen if it gets to a point where it needs to be. All righty. Is there anything that you would like to end with, or
Omar, for you and Dr. Kingslow, this whole issue of bronchitis, in my opinion, it's been that many folks are afraid to make the diagnosis of asthma and like to call it, oh, I just have a little bronchitis. Could you comment about this? I'll say fear of making the diagnosis of asthma and thinking that a little bronchitis is okay, and when a lot of these folks really have asthma?
Well, I think that, it goes along with any other disease state. People just don't want to be labeled with a tag that commits them to a chronic disease entity. And we see that in the medical community as well. I have tons of patients who come into me and I tell them, you have asthma, and say, no, my internist told me that this is just bronchitis. I said, well, you probably haven't had bronchitis, but you're walking in the door today with asthma. I think people just want to avoid being labeled with long-term disease. And with that, people get undertreated because of it.
What tests do people have to do to diagnose asthma?
Oh, great question. So there's a number of ways to diagnose it. You can do spirometry, and what we look for is a limitation in your airflow, as evident by your FEV1, your forced expiratory volume at 1 second over your forced vital capacity. Or if those numbers are normal, we give you a bronchodilator challenge. We give you 2 puffs of a bronchodilator, and then we look for an improvement in your airflow, either a 15% improvement in your FVC or FEV1, or a 50% improvement in your smaller airways, your FEF 25 to 75. That's diagnostic. An alternative way to diagnose it is to give a patient a trial of an inhaler. You give them the inhaler, their wheezing goes away, you've made the diagnosis. A third way to make the diagnosis is to give patients a peak flow meter and have them, when they have symptoms, measure their peak flows. If they see a substantial drop in their peak flows relative from their baseline, that's diagnostic as well. And then the last way to diagnose it, say, for instance, you've done all these studies and nothing's panned out, I send patients for what's called a methacholine challenge test. And methacholine is a bronchoprovocator. It's going to cause if you're hyperreactive, it's going to cause your airway to clamp down. And we'll see a drop off in their spirometry post methacholine. So those are the ways in which we are able to diagnose.
I used to have kids come in and I do the peak flow, and if it's abnormal, I give them a bronchodilator, have them repeat it, and it goes up. The issue is you have to want to make the diagnosis. If you don't want to make the diagnosis, you won't make it.
Right. But also understand the difference between asthma and bronchitis is that asthma is not infection. There's no infection associated with asthma.
Right.
Bronchitis, actually, it's an infectious process that's a part of the bronchitis, the disease of bronchitis. There is an infection associated, I should say, put it that way.
Mm-hmm. And, as we stated earlier, similar to bronchiectasis, because of smoking and the injury that's sustained to the airway and the immune response of the airway from tobacco, our ability to fend off germs that we're always exposed to is now truncated. So we have an increased propensity for developing bronchitis. In addition to that, because the architecture of the lung is now mutated, we're at an increased risk for malignancies, reducing our tumor suppressor cells in the lungs, upregulating those mutating cells in our lung, and increasing our risk for malignancy. So
excellent. Well, I trust we could go on and on and on, but it is time to end this party. So, Dr. Kingslow, I just so appreciate you coming on and bestowing all the knowledge that you have. Brother, you're doing it up there in DC, and I got to come up and say hi to you one day.
By all means, I
Yes,
thank you
yes.
for inviting me, and I thank the panel for also being here. Great questions and a great dialogue back and forth, and I'll be looking forward to joining you again in the future.
All righty, all righty. Okay, so in ending, let me just make some closing remarks. I'd like to thank OBHealthy for allowing us and presenting, the Doctor's Lounge so that we can bring this information out there to the world. Understand, every second Saturday at 1 o'clock, we're here. All righty, and if you would like to check out the past webinars, please go to OBHealthy and just click click the doctors area, and you'll see the YouTube sign. Bring up our past webinars. The information is invaluable, and I just trust each and every one of you will. If you have a problem, look at that direction as far as getting more knowledge, so that when you go to your doctor, you can really explain and understand what he's talking about when he talks about your problem. Remember, it's caring and sharing. Let people know about it. Let your church members, friends, family, even your enemies know that we're here. And please, the most important thing that I can say, do not change any aspect of your medical care until you see your private physician or healthcare provider, because only they can truly take care of your medical problems. All righty. Until next month, listen, I'm going to say peace out, everybody. And I just so enjoyed this webinar. Dr. Kingslow, again, thank you for taking the time and bestowing all the knowledge on us. Until next time, peace. Take care, everyone.
Thank you.
Take care.